What did you know about the patient's, was it progesterone receptor positive? Was it estradiol receptor positive? Do you know those questions on that particular patient?
Yes, I do. And of course, and I hate to say this, the oncologists are not hormone doctors.
No,
So
absolutely not.
the most common patient has an estrogen positive tumor and a progesterone positive tumor. Some of them have Herceptin positives, some do not. For estrogen positive tumors, giving them estrogen or estradiol will stimulate that receptor. Um, and of course, that's why most patients that have cancer get aromatase inhibitors or tamoxifen to block that estrogen receptor, because estrogen can stimulate that receptor. The opposite is true of the progesterone receptor. If you have a progesterone positive receptor, that's good. If you have an estrogen receptor, that's actually good for the outcome, but you don't want to take estrogen because it'll stimulate that receptor. But a positive receptor for progesterone stimulates the tumor to become apoptotic. So stimulating the progesterone receptor causes the cell to go in an apoptotic phase. Stimulating the estradiol receptor with estradiol causes the tumor to grow. So probably should not take estradiol. The doctors will be absolutely against that unless you read Bluming's book, Estrogen Matters, where he says, yes, but all the outcome studies when they gave estrogen to women with breast cancer decreased the risk of recurrence and made them live longer. But that's a whole other story.
Right.
But
I mean, can I comment on that really quick?
sure.
I mean, if you think about it, and I'm just a pharmacist, but when I remember learning about cell division, and when cell is in a differentiation stage, that is when it is at most risk for cancer. And if estradiol helps cells proliferate to the final form of a correct cell, whether it be a breast tissue or whether it be uterine tissue, so if it helps it differentiate into that final good form of a cell, then estradiol would actually make sense that estradiol would actually help breast cancer.
Well, it does, but that's difficult to explain because
Yes.
we all know that the oncologist will say, no, you have to block the estrogen positive receptor because the studies show when you block it, it will decrease recurrence. But giving them estradiol or estrogen also decreases recurrence. And as you know, that study published in JAMA 2 years ago, the only drug in the world that has been shown to be successful in reducing breast cancer mortality it's not an AI, it's not tamoxifen, it is estrogen. Well, wait a minute, but they got a positive estrogen receptor. How can you give somebody estrogen if they got a receptor? That's why you can't give estrogen to a woman with estrogen positive breast tumors, because the oncologist will say no and they will have a fit. But then the patients will come to us and say, yeah, but what about Bluming's book? What about all these 60 studies to show that in women that had breast cancer that took estrogen, in every single study, there's a reduction in the risk? Well, you have to understand what goes on inside the cell, which is beyond the scope of this talk. It's the insulin and glucose inside the cell that's driving the disease and increasing the aromatase enzyme that increases the cellular estradiol inside the cell. Well, yes, and if you block that, it will reduce it. But you also don't understand with the estradiol, it will reduce the reduce the insulin and glucose inside that cell that's driving the disease. And that's what people don't grasp and understand, and the oncologists will not. But you have to look at outcome studies where there's a benefit in taking estrogen in outcome studies. Yeah, there's 60 studies to show in women with estrogen positive tumors, there was benefit in outcomes. And it was the only drug that reduced mortality long term. The AIs do not, the tumors come back. Tamoxifen, the tumors come back. With estradiol or Premarin, the tumors can come back, but at a much lesser rate than with tamoxifen or with an AI, which is why the study proved long term, it's the estrogen that reduces breast cancer mortality. And there's no other drug that does that. So that's the estrogen side of it. But don't give estrogen to a woman with breast cancer because the oncologist will have a fit.
Right.
But
So,
read Bluming's book, Estrogen Matters, and you'll understand
okay.
why estrogen works in women that have breast cancer. But to answer the question of progesterone, yes, progesterone is extremely important. Tilly's studies last year published in Lancet Oncology showed and proved that progesterone in very high dose is very apoptotic to breast cancer cells and should be used. But most doctors think progesterone receptor, no, you can't give progesterone because progesterone is medroxyprogesterone acetate. That makes the tumors worse, so no hormones, and we'll ignore all of Tilly's and all those studies because they just don't know it or understand it.
For our listeners and viewers, Dr. Rouzier, that don't know what apoptotic means, will you explain what apoptotic means?
Apoptotic means it kills the cancer cell.
Boom.
So stimulating the androgen receptor with testosterone kills the cancer cell. It's apoptotic to the cancer cell. Stimulating the progesterone receptor with progesterone is apoptotic to the cancer cell, which kills the cancer cells, which is why progesterone is so important in breast cancer patients. And that's why testosterone is so important in breast cancer patients.